name is Sua Yoo. I'm a clinical physicist at Duke University Medical Center. Today, my presentation is clinical experience with machine learning-based automated treatment planning for whole breast radiation therapy. Here is disclosure. I don't have anything to disclose. Machine learning-based automated treatment planning tool has been developed and evaluated for breast radiation therapy planning at Duke. Today, I would like to share our experience in clinical implementation of in-house AI planning tool and provide some guideline how to implement an AI planning tool. Here is outline for this talk. I'll give introduction for breast planning and machine learning-based AI tool and go through some of the process of our clinical implementation. First, let's talk about treatment planning techniques for whole breast radiation therapy. 3D conformal radiation therapy is the most common and traditional technique for whole breast. It utilizes tangential beams with MLC and wedges. Field-in-field technique includes subfield with MLC modified from the main field from 3D CRT, and it can reduce high dose area further, and also it can increase coverage even more than 3D CRT. Irregular surface compensator, or also known as electronic compensator technique. It uses tangential beams, but it involves fluence maps for intensity modulation. It utilizes dynamic MLC delivery. The planning process requires repetitive manual fluence editing and dose calculation. Imrt and Vmat goes through inverse optimization process to achieve optimal fluence map for multiple beams. There are some studies done to compare different treatment planning techniques. And this specific study compared 3D CRT, field-in-field, and irregular surface compensator techniques. The results showed very compatible target coverage and the similar long dose and hard dose among all these three techniques because they all use very same beam settings and same aperture openings. Noticeable difference appears in the dose homogeneity, high dose volume, volume 105. Field-in-field reduced high dose area compared to 3D CRT, and irregular surface compensator further reduced inhomogeneity. How about comparing with Imrt and Vmat? Irregular surface compensator technique costs less because it uses forward optimization, so it's cheaper for patient than Imrt or Vmat. It can still provide a very high quality plan compared to Imrt and Vmat because irregular surface compensator also utilizes intensity modulation. But there's one benefit, that's low dose spill for lung and heart and contralateral breast from the irregular surface compensator technique. So this shows the isodistribution of three different techniques. Contralateral breast and lung and heart receives a lot lower dose than Imrt or Vmat. Because irregular surface compensator technique has great advantage for plan quality and with low cost, Duke University has been using it more than 10 years. The planning process involves first, the planner generates initial fluence map using treatment planning system. Then planner manually edits the fluence map to remove the fluence for the blocked area like heart and add the fluence for skin flesh area. Then those calculations should be done and plan should be reviewed by planner. Planner again then manually edits fluence to increase the coverage and to improve inhomogeneity. Each time of manual edit is done, those calculations has to be done again. Then planner should review the plan. And planner should repeat this process until satisfying dose distribution is achieved. So here is the initial fluence map from irregular surface compensator technique from the treatment planning system. Does not have the block for the heart and it does not have skin flash area. So planners manually edit, remove it, and add the fluence for this area and run those calculations and add fluence to increase the dose and lower the fluence to decrease the dose. And this shows the final fluence map from the manual editing. Here's the isodose distribution comparison. This is just from initial fluence map from treatment planning system, and this is after repetitive manual editing. The coverage here is similar, but coverage in certain area from initial fluence map is not good enough. And the final plan actually shows good coverage. And also the inhomogeneity is pretty bad with just initial fluence map, and the planners manually edited and achieved the good distribution. So irregular surface compensator technique works really good for good plan quality. Then what's the problem? The major disadvantage from the current irregular surface planning comes from repetitive manual fluence editing. It takes time, and plan quality heavily depends on planners' experience, judgment, and planning time. If they have to rush, plan quality goes down. And we also have to invest long training period with learning curve. To overcome this disadvantage of irregular surface compensator, we need AI planning tool. And this paper discusses why we need AI for treatment planning. Obviously, efficient planning that will reduce the planning time and standardized method, and it's going to provide a consistent and improve the plan quality and not reliant on individual performance or experience. So our Duke Medical Physics research team started developing AI planning tool. The goal was for efficient treatment planning process. This diagram shows the planning process. Right side is the manual treatment planning process, and left side is AI planning process. Research team identified which part to be automated. Obviously, manual fluence editing and repetitive dose calculation in this loop was going to be replaced by AI planning tool. Our AI planning tool was developed based on machine learning technique. It predicts optimal fluence map for whole breast treatment field. And the predictive model is learned using the past training cases, and it produces output for future cases. From the patient feature like CT images and DRR, the predictive model, it generates pixel-wise fluence map. Therefore, balanced dose distribution is the result we get. Now we have this AI planning tool developed from the research project. And what should we do for clinic? Can we use it? So we made a roadmap to implement in-house AI planning tool. First step is the designing phase. That's done already. AI tool was developed. And now the second step is the validation study. This validation study was performed in conjunction with the designing phase during the development. We used the training cases, 20 cases for training, and we used another 20 cases for validation study. And this is to ensure that AI planning tool works properly. And this study was published in 2019. This is the validation study result for 20 validation cases. The coverage was very similar with AI plan and the clinical plan from manual planners. And isodose distributions were very similar for large size breast and small size breast, and various cases we verified it. Now after validation study, we go through preclinical implementation phase. This AI planning tool was moved from research environment to clinical environment. Eclipse treatment planning system, scripting application programming interface was used. And we selected 30 cases for test. And that's a preclinical implementation that's different from validation test. And then also we include the end-to-end test for some selected cases. That includes after AI plan is done, we need to make sure that we can actually deliver this AI plan. So we go through electronic charting and ensure some physics chart check, and we deliver QA using portal symmetries, and that ensures the safety. This is the result for the 30 cases in clinical environment. Again, we got very good comparable target coverage when we compared the manual plan versus auto plan. And those inhomogeneities were also very similar. Auto plan was a little bit better, but not significant. Maximum dose was very similar. Again, hard dose, long dose were very similar because they were using exact same beam setting. But planning time was reduced dramatically. It was about 2 hours for manual planning, and for auto planning, we spent about 6 minutes. So we achieved our goal. We made treatment planning very efficient. After this clinical implementation study, we gave presentation to the department. Then we trained the symmetrist, and we had a few discussion sessions with the clinical team and went through questions, answers, and mainly people had safety concerns and workflow questions. Then we developed the user procedure. After that, the next phase is to use it. We launched AI planning tool in May 2019 for clinical use. From this point, all breast cases at Duke Main campus were planned using AI planning tool. In 2020, 5 satellites started using it. So far, we estimate about 1,000 patients were treated using in-house AI planning tool. Our clinic workflow remained the same, and we told the planners that they can modify fluence after AI plan is done. As we started using AI planning tool, we performed prospective study that was part of performance evaluation. From May to December 2019, we put all patients in this study. That was total 1 or 2 cases. And breast patients who were not included in this study were treated using Imrt or Vmat, so that was totally different techniques, so we didn't include those patients. First, auto plan was done by using AI planning tool, and no manual editing was done, and we saved it as auto plan. Then planners were free to modify fluence map after they reviewed the plan. Maybe they thought they could improve, so they modified it to improve the plan. And they saved it as final plan. We compared auto plan versus final plan. And the purpose of this study was AI plan alone good enough? Or do we need to do more to improve it? This slide shows patient population. We have total 1 or 2 patients and divided into 2 groups, group 1 and group 2. Group 1 was patient without nodal irradiation, and group 2 was with patient with nodal irradiation. This is the study result. For group 1, without nodal irradiation, target coverage was very similar in auto plan versus final plan. They were not much different at all. For group 2, target coverage for breast, chest wall were again very similar, not different. And supraclavicle target was also very similar. But IMN coverage was somewhat different, although this one was statistically insignificant. But we noticed that the difference was in IMN coverage. Obviously, final plan had better IMN coverage. Then how about dose homogeneity? Auto plan and final plan were not much different for group 1. It means fluence editing after AI plan was done was not necessary for group 1. But for group 2, manual fluence editing indeed improved the plan. So it means AI plan was not good enough. Hard dose, long dose were very similar because they had exactly same beam setting. And the planning time for group 1 with using AI was about 12 minutes. In final plan, it added about 13 more minutes. So total planning time was about 25 minutes for group 1. Total planning time for group 2 was about 42 minutes. This is comparison for one of group 1 patients. This is auto plan and this is final plan. The coverage and the dose homogeneity were not much different. And even though planner actually modified the fluence, we could not see much of difference. A little bit of difference in the skin flash we noticed. But overall, planner didn't really modify much. This is an example case for group 2 with the nodal irradiation. This is the auto plan fluence map, and this is the final fluence map with some manual touch. We noticed that the superior junction area, the high dose area got reduced because the fluence got removed manually, and also IMN area, planner manually added more fluence for better coverage for IMN. So this performance evaluation, we compared auto plan versus final plan. What we learned are it's working. Our AI planning tool worked fine for all breast cases, and we could treat breast cases using this AI plan. And we also learned the planners continued manual fluence editing at the end of AI planning for most cases. And it's probably their habit, they are used to do manual editing, so they still did it. Only 3 patients out of one or 2 patients did not have any fluence editing done by planner. And those manual fluence editing wasn't necessary. We learned that for group 1, it was not necessary. Planner modified the fluence, but the dose distribution was not different. It didn't really improve coverage or it did not improve homogeneity. The planner just updated the manual fluence because they feel comfortable that way. But for group 2, yes, manual fluence editing was necessary because it improved the IMN target coverage and also it reduced 105, 110, and Dmax area at the junction with the tangential field and superclavicle field. The AI planning tool we developed was for tangential only cases, and training cases used tangential only without nodal irradiation, and validation was performed for cases without nodal irradiation. Therefore, it makes sense that group 2 showed a suboptimal auto plans and manual fluence editing was still necessary. However, when we compare full manual planning without any AI involved, or a plan with AI plan with some of manual fluence editing, time difference was we still could save about 2 hours, 3 hours of planning time. And we also found that there are some outlier cases and very large patients that need about more than an hour of manual fluence editing in addition to AI plan. And these cases would be taken probably 4 hours if we just do completely manual fluence editing. And maintenance part, what should we do? It's mainly about documenting and testing. So for product development, product is already developed, but we need to document what this product is for. Scope, aim, workflow, and product design, and also user procedures should be documented. And all the process of test, code review, validation, commissioning, and routine QA procedure and report should be documented. And whenever we have any upgrade, we need to do release note and version control, and we need to make a procedure. And important thing was we had to keep log file what's done on each date. Now, next part is improvement. What are we going to do for future? So for AI planning, what we learned will feed into the next product. We learned that cases with nodal irradiation, we needed manual fluence editing, and that's because AI planning tool did not learn those contribution from superclavicle plan. So for the next version, now AI planning tool should learn those distribution from superclavicle plan contribution. And also, users gave some feedback that there are some manuals that we have to import fluents, we have to select energies. These can be automated as well in the next version. And some of the flexibility, we wanted to combine this irregular surface compensator field with the 3D field. And also we need to combine various beam energies. That flexibility should be given to users. And some of customization should be done to prioritize coverage for any specific area and prioritize homogeneity versus coverage, minimum dose, maximum dose, and users should be able to customize. Here's a summary of this talk. We reviewed the breast treatment planning technique and reviewed machine learning-based AI planning tool and went through clinical implementation process and performed evaluation for AI planning tool. If you're developing an AI tool for clinic implementation, you draw diagram, what to be done, make a roadmap, and work with your team to achieve this clinical implementation. Thank you.